I'm not sure that any of you really appreciate how much we as chiefs stress about this day. Much to Dr. Salcedo's dismay, I'm sure we agonize much more over this than Absite, our chief here. And the reason is this podium in this room has a very special place for us as trainees. This is where we learn, where we grow, where we're often humbled here as we present. And so it really is a privilege to be able to stand here. So thank you for continuing this tradition and allowing us this. So this morning, I want to talk about the science of compassion. There seems to be a disproportionate amount of tragedy in our community these past few months. In fact, the world at large, there's just a greater awareness of the fragility of life. Russia invading Ukraine, talk of nuclear weapon testing in North Korea. And closer to home, the threat of violence with something as mundane as going to the grocery store or taking your children to school. As a department, we have lost spouses, parents, friends, and even some of our own. A few months ago, I was reminiscing with a friend about surgical residency, and they asked, would you do it again? In a field that demands as much as ours, it deserves some questioning. We give up an enormous volume of our lives to this profession. We miss birthdays, holidays, anniversaries, dance recitals, vacations. And compared to other professions, we don't really get compensated enough to make it just an economic argument for the sacrifice. I think it is not only reasonable but necessary at times to take pause and to ask, is it worth it? This is not an instructional talk in any way. My goal is not to educate you, but to ask you to think, to reflect on your own experiences, and ultimately to remind you of the privilege it is to be entrusted with the lives of another human being. So in order to talk about compassion, we first have to understand the idea of empathy. Empathy is the ability to understand and vicariously experience the feelings of another. It's the first step towards compassion, and it leads to incredible things for both us and our patients. However, this ability to experience another's pain is an occupational hazard when you work with dying people. For a moment, I want you to think about the first patient you watched die. I wish I could say I remember the name of every patient I've lost, but I do remember the first. My first exposure to death was here at UC Davis as an auditioning fourth-year medical student. I was shadowing on the trauma service when morning report was classically interrupted by a 911 trauma activation. I followed the team down to B-Pod in the ED. Had I known this meant we were waiting for a pediatric activation, I might have prepared a little differently. We all pile into the room that was way too small for the group, and I was given our classic blue plastic gown and gloves. There was the normal flurry of activity as the nurses prepared the Belmont, moving extraneous equipment out of the way, and my chief asked what was coming in. The nurse read the fragmented triage note. This was a 5-year-old girl struck by a car at high speeds while walking down the street with her sister, and she was coming in under CPR. The change in the room was palpable as this registered. But the activity continued until the paramedics frantically rolled down the hall with the gurney performing compressions. My chief looked at me and asked if I knew how to do CPR. I nodded numbly, and the girl was transferred to the bed as we took over compressions. I'm sure there was more information passed, but all I could see was the lifeless body of this little girl wearing nothing but Disney princess underwear. I was third in line for compressions, which was the only thing I was remotely qualified to do in the room. I'd only ever done compressions on a dummy, and as I pushed, her chest moved with an astonishing compliance. I could feel her already cracked ribs under my hands with each push, and nothing in medical school had remotely prepared me for that. I kept my composure, keeping up with the pace of the room, and after what seemed like hours, the code was called. The team slowly filed out of the room, leaving behind the chaos of blood and PPE littering the floor. In that moment, my world was shattered. I had just watched a 5-year-old girl die right in front of me. She was the same age as my niece at that time. It's been 7 years, and I can still remember everything, down to her pink, sparkly fingernail polish. I also remember the silence in the elevator as our team slowly made our way to the 11th floor to start rounds. And then I remember that as quickly as it all started, everything went back to normal. The monotone voice of the post-call intern started with Mr. Smith, a 45-year-old man, status post MDC, post-up day 4 after an XLAP and splenectomy. And just like that, life started moving on. This was my first lesson in moral injury in medicine. Everyone on that team was affected. It was palpable. But this was 9 a.m. at the start of a 24-hour shift, and there was a list of 35 patients to round on. There was no time to be paralyzed. You gathered yourself, you moved on. I tell this story not to elicit an emotional response or to detail the horrors of what we sometimes encounter in our job, but to emphasize the power of empathy, because I'd be willing to bet that many of you in the room felt something in that story. And that's simply hearing the event as a third-party observer. The ability to intensely experience another's pain is an occupational hazard. There are two components of empathy. The first is affective empathy, which is what we more traditionally think of, and this is the ability to vicariously experience what someone else is feeling. The second is cognitive empathy, which is the understanding of another's emotion without necessarily experiencing it for yourself. There have been numerous studies describing the way our brain experiences this process, and functional MRI has taken this to a whole new level. In a recent meta-analysis by Lamb, they took 32 imaging-based studies and looked at the associations between empathy, experiencing someone else's pain, and personal pain. They took these collective images and layered them together to identify core neural networks. What they found is that there's significant overlap in the areas of the brain that are activated during direct experience of pain and those activated during empathy for someone else, specifically the anterior insular cortex and the cingulate cortex. This was the underpinning for the idea that shared representation of self and other are at the core of the phenomena of empathy. Some empathy is a good thing, but when it reaches a certain threshold, it shifts from motivating compassionate behavior to motivating self-protective behavior. Feeling another's pain can clearly make us vulnerable, but what happens when you're watching the pain of someone that you had a role in creating? This brings us to the concept of moral injury. Moral injury is a phrase that's thrown around a lot and often incorrectly. It's actually a term that was used to describe a syndrome seen in Vietnam War veterans in the psychology literature. What was interesting when I started reading about this is that it refers not to experiencing someone else's trauma or bearing witness to tragedy, but as being part of its cause. It's described as feelings of shame, grief, and remorse from having violated core moral beliefs. It's a betrayal of what's right by someone who holds legitimate authority in a high-stakes situation. So there's an assumption of fault, of responsibility, of transgressing your own moral code, creating an inner moral tension. Put into the medical context, this makes perfect sense to me. Our fundamental oath is to do no harm. So what happens when we violate that? What happens when we are not mere bystanders to another's tragedy, but part of it? That creates an ethical tension that many of us experience but rarely address. And this doesn't have to be as dramatic as making a mistake that costs someone their life or shooting someone from the front lines. Many of you know my wife Sadie works as a burn nurse in the Shriners ICU. She takes care of children who have been seriously burned. She is one of the greatest empaths I know, which is why she chose that career to begin with. She loves that her skills and her hands are directly related to these patients' outcomes. But doing dressing changes on burned children is quite frankly brutal. It requires incredibly high doses of pain medication and sedatives, but the pain is never zero. And this process is not optional, it's required to heal. This means that at times her job demands immediate actions that violate her core moral beliefs, which is to heal and not harm. That is moral injury. When your actions, either in perception or reality, violate your own moral code, thus creating internal tension. This term is distinct from burnout, though it's certainly related. Burnout is a quantifiable spectrum that's the end result of the cumulative insults that we incur in our job. Many of these are physical and encompass the typical things that we associate with burnout. But if we reduce burnout to simply the constellation of exhaustion and underappreciation, we miss a huge part of the problem. And that can never be addressed by work hour restrictions and wellness events. We have to recognize and address the problem of moral injury if we're ever going to solve the issue of burnout. So empathy seems to both self-select for helping professions, but then at the same time It sensitizes us to moral injury, leading to burnout. So on the is it worth it pro-con list, it's not looking great so far. But compassion is the key. And this is where the story starts to shift. Compassion is a feeling of concern that is distinct from empathy in that it's accompanied by a motivation to help, to alleviate that suffering. And what's fascinating is that while empathy activates pain centers in the brain, compassion actually activates centers in the brain that are involved in reward and pleasure. In fact, subjects who underwent compassion training and then were exposed to the very same stimulus that previously evoked intense activation of pain centers had less activation and then were able to experience empathy without being so overwhelmed they had to transition to self-protective behaviors. So this is a fascinating process. Empathy creates discomfort as we deeply identify with someone else's pain. When we then take action to alleviate that pain in the other individual, as a byproduct, our own sympathetic pain is relieved, which triggers reward pathways. That is why compassion is the antidote to moral injury. And if this seems like a very selfish motivation for helping others, you are absolutely correct. Emerson captured this perfectly when he said, "It is one of the most beautiful compensations of life that no man can sincerely try to help another without helping himself." So compassion is the key that converts the potentially negative process of empathy into a cycle that unlocks the process of reward. It's a mechanism of emotional regulation that enables the empath to both manage their own feelings and also care for another in distress. And this is why escapism doesn't work when you're talking about burnout. There's an absolute necessity for work-life balance, and I by no means advocate abandoning work hour restrictions or ignoring mental and physical wellness. But they still only address part of the problem, because pulling away and creating emotional distance is not the solution to moral injury. There's certainly a role for embracing good things in life and having time away, but to address the deeper issue requires a determined leaning in and pursuing meaningful human connection, not avoiding it. In fact, this is what promotes resilience, because your ability to receive fulfillment is no longer attached to yourself. Follow me here. If the positive feeling and emotion, or more scientifically, your reward pathway activation, is solely dependent on your own needs being met, receiving positive affirmation, being well rested, well fed, then in many scenarios, i.e. a surgical residency, there is no means of finding personal fulfillment for the vast majority of your time. But if those reward pathways are activated in pursuing the interests of other people, then even in the worst of circumstances, there is the potential for fulfillment. In fact, there are many studies demonstrating increased parasympathetic nervous system activation and even oxytocin release with compassionate action. There's a large body of evidence that our likelihood to act compassionately is significantly impacted by factors of shared identity. But what we've also found is that how we identify with our so-called in-group is a very dynamic process. One such study was made popular on the Hidden Brain podcast, The Empathy Gym. In this study, Manchester United soccer fans were recruited, and in the first part of the experiment, they were asked to sit down and write about how much they loved Manchester United, why this was their team, the team's success and failures. After this portion, they were told they were going to a different building on campus to watch a video about soccer. During this transition, they encountered an actor who appeared to fall and hurt his ankle in front of them. In some instances, this actor was wearing a Man U jersey. In others, he was wearing a Liverpool jersey, a well-known rival team, and in some a neutral jersey with no team affiliation. Not really unexpectedly, they found that subjects were much more likely to stop and help the individual wearing the Man U jersey compared to the Liverpool jersey, I think 90 versus 30%. What's more interesting, though, is what they found when they repeated this study. So this time, instead of asking the participants to write about why they loved Manchester United, they asked them to write about why they loved soccer as a sport, why it was such a beautiful game. There was no focus on team affiliation. And what they found was that this time, the individuals were just as likely to stop and help the individual in the Liverpool jersey as they were their fellow Man U fan. This is incredible. You can manipulate compassion by simply altering the internal dialogue, adjusting your mindset. Both groups were writing about something they had an incredible passion for. The difference was the inclusivity of the dialogue, not a fundamental difference in the moral makeup of the subjects. And this gets to the concept of moral expansiveness, which in today's cultural climate is invaluable. Moral expansiveness is how we define our in-group. It's the demarcation we use to distinguish those that we deem worthy of our moral concern and treatment. This is multidimensional and has obvious implications on our social interactions. Compassion is a dimension of social ethics that invites us to expand those moral boundaries to those who are different from us. This is why inclusivity and diversity matter. Diversity is not a matter of fairness. It is a moral and social necessity. And this combats tribal empathy, which is a primal form of empathy where our concern for those who are like ourselves is so intense that it then prohibits us from demonstrating empathy to those who we see as different or as outsiders. The more we surround ourselves with different people, ideas, cultures, and color, the more we exercise that native ability to experience the feelings of others and thus broaden the reach of our compassion. Not that long ago, I was standing here at M&M talking about the last patient I lost. I was on my ACS rotation a few months ago when we were transported a 32-year-old man from another hospital. He'd been in the ICU for several days. I'd taken him to the OR multiple times. He was young, a triathlete. He had every reason to pull through, but we just could not get ahead. I had many long conversations with his brother, his mother, and his newly pregnant wife about his condition. Unfortunately, he ultimately was overwhelmed by sepsis, became coagulopathic, and he spiraled to a point from which he would not recover. We discussed his guarded prognosis with his family, and they decided to withdraw care. He was compassionately extubated on a Sunday afternoon, and he died shortly after. Following this, the nurses, the respiratory therapists, the residents, and the attendings involved in his care gathered at his bedside with his family for a moment of silence. After this, his mother, his siblings, and his wife came, and they hugged me. Just hugged me and sobbed. In the time of COVID, that was staggering enough, but what was even more surprising is that then they thanked us. You want to talk about being humbled? Here was a young patient who had every reason to pull through and survive, and despite all our efforts, we failed to rescue him and he died. Never having met his unborn daughter, leaving a widow and a grieving family behind, and they thanked us. But for what? All I'd ultimately been able to contribute in any way was a human connection. But somehow that mattered. And while this may be an extreme example, there are many instances in medicine where at the end of the day, all we can offer is a simple connection, respect for humanity, and genuine compassion. But what was really interesting in this case is that I went through every step of this patient's care with my own medical student. It was her first week on her surgery rotation, and she was my shadow through all of this. She sat with me for hours talking to his family. She went to the OR for his washouts. She rounded on him every day in the ICU. She was not there the day he died, but this was her first exposure to death in medicine. And maybe in part because of my own experience as a medical student, we sat down the following day to process this. We talked a lot about the hard things in medicine, some of my own failures. I told her about his family the day he died. And in an oddly intimate way, I felt like I was able to pass down a piece of what we do as doctors and as surgeons that can't be read from a textbook or taught from a podium. Our ability to connect with human beings and be given the privilege of experiencing with them their most vulnerable moments, their joy, pain, grief, and at times, even their mortality. This is part of what we do in medicine that's been recognized from its birth. The Hippocratic Oath, which we all know so well, speaks poignantly to this. It says, "I will remember that there is art to medicine as well as science, and that warmth, sympathy, and understanding may outweigh the surgeon's knife or the chemist's drug. Most especially, I must tread with care in matters of life and death. If it is given me to save a life, all thanks. But it may also be within my power to take a life. And this awesome responsibility must be faced with great humbleness and awareness of my own frailty." To conclude, I wanted to briefly talk about some of my own beginnings. Medicine was not really at all on my radar growing up on a small farm in Virginia. I loved animals, and I quickly fell in love with science and this understanding of how the natural world works. I needed a way to pay for college, and so through some family connections, I was offered a job with the Department of Social Services, working at the Bedford County Group Home. This was a pretty unique situation where teenage girls who had, for all intensive purposes, failed out of the foster care system, usually due to violence and substance abuse, would come and they would live together in a home. 8 girls and case aides who took on the role of sort of a mentor or parent. I was certainly out of place as the only science major working with a staff of psychologists, but at 19 years old, I was sitting in the director's office for an interview. My soon-to-be boss said something that transformed my perspective in that role and has carried over into my current career. He said, if you approach this job with the attitude that you can fix these girls, you will be perpetually frustrated, discouraged, and ultimately burn out and fail. The only way to succeed is to approach this with the attitude that you are loving the least of these, and there is value in that, regardless of the result. In my 5 years working in social services, I found that to be undeniably true. And now at the end of my surgical training, I believe it to be just as true in medicine. We cannot fix every patient. We will fail. We will make mistakes, and even hurt the very patients we've taken oaths to heal. But if we can approach this job, this calling, with the attitude of loving the least of these, then I believe we can impact our patients, our colleagues, our community, and in that process, find a deep fulfillment for ourselves, which will further propel us to empathy and compassion. Which is why I propose that the antidote to moral injury and the resulting burnout is not working less, not escaping emotional vulnerability, but motivating our work with meaning, cultivating empathy, embracing those who are different from ourselves, and finding ways to love the least of these, regardless of the result. Can't finish a talk like this without expressing a lot of thanks, because the reason that we stand here is because of all the people who aren't. First, to UC Davis, to Dr. Farmer, Dr. Salcedo, thank you for being unapologetically committed to creating a culture of diversity. It has been truly a privilege to train and grow up under your leadership. Thank you for taking a chance on a Virginia farm girl who didn't necessarily meet the standard surgical pedigree. To my attendings, it would take an entire lecture to name each of you and describe the incredible impact you've had on me as a surgeon and as a person. I think I only am starting to understand the weight of entrusting other people with your own patients' lives now, as I'm kind of standing on the brink of that, and how truly terrifying that is sometimes. To the trauma nurse practitioners, to the SICU nurses, you all are the ones who taught us how to be doctors, and throughout residency have been a constant source of support and encouragement. Thank you. To my co-residents, I would not have made it through this without the sometimes many post-call beers, campfire conversations, door-dashed meals in the call room. You have reminded me so many times of the joy in medicine as a team endeavor. And especially to the junior residents. Working with you has been an unexpected joy for me this last year of residency. Thank you for your patience as we try to make this transition from student to teacher and all of the challenges that come with that. Thank you to my parents, who are truly the greatest empaths I know and lived out the raw and sometimes very messy reality of what it means to put others before yourself. And my siblings, who have become my best friends and each are in their own way real-life heroes of compassion for me. To my wife, watching the way that you care for people around you is nothing short of inspiring. You have empathized with my own pain, borne the brunt of my moral injury, and shown me incredible compassion. Without you, I would never have made it through this season, and there's no one I would rather take this next step with than you. And last but not least, this presentation would not be complete without acknowledging the contribution of the canines in our program. You are a source of constant emotional support, laughter, and usually single items of footwear. Ernie, you are the best of all of them. Thank you.